Hello everyone, I'm Dr. Surbi and today we'll be discussing sepsis. So sepsis, how it is defined. According to the latest Sepsis 3 Task Force Guidelines, sepsis, it is defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So, this is the latest definition of sepsis, that is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. And now the latest septic shock definition has also been changed, now defined as in presence of sepsis if there is persistent hypotension, so that we not only require fluid resuscitation but also requires vasopressors to maintain a mean arterial pressure of more than 65 plus a serum lactate levels of more than 2 millimoles per liter. So, new definition of septic shock as given in JAMA 6 2016, it says that in presence of sepsis, if there is a persistent hypotension, so that we require vasopressors along with the volume resuscitation to maintain a mean arterial pressure more than 65. That is, the volume resuscitation is not adequate enough to maintain a mean arterial pressure above 65 plus a serum lactate level of more than 2 millimoles per liter. So sepsis is a disease continuum which includes infection leading to SIRS, sepsis, severe sepsis and septic shock. So first we'll discuss SIRS. So SIRS was given by the American College of Chest Physicians Consensus Conference. SIRS, it has 4 criteria. First, temperature, heart rate, second, heart rate, third is respiratory rate, and fourth is WBC count. So 2 out of these 4 criteria are considered as a definition for SIRS. First, we'll discuss the full form. SIRS stands for Systemic Inflammatory Response Syndrome. Systemic Inflammatory Response Syndrome. 2 out of the 4 following criteria should be fulfilled for the definition of sepsis. So, these criteria include a temperature of more than 38 degrees Celsius and or less than 36 degrees Celsius, a heart rate of more than 90 beats per minute, a respiratory rate of more than 20, or a arterial pressure of carbon dioxide less than 32 millimeters of mercury, and a WBC count of more than 12,000 or less than 4,000. Also, more than 10 band or more than 10 immature band cells present. But according to the latest Sepsis 3 Task Force, the SIRS and severe sepsis have been eliminated from the disease continuum. They now only include sepsis and septic shock. As already discussed, sepsis is the life-threatening organ dysfunction caused by a dysregulated host response to an infection, which causes a hospital mortality of more than 10%, while septic shock is sepsis with persistent hypotension, which requires a vasopressor along with fluid resuscitation to maintain a mean arterial pressure of more than 65 millimeters of mercury plus the serum lactate levels more than 2 millimoles per liter or more than 18 milligrams per deciliter. So we have to remember that septic shock has a high hospital mortality of more than 40%. So the first step in implementation of an optimal sepsis treatment is identification of the patients with sepsis. So early detection is very important. Early recognition and diagnosis of sepsis is required to prevent it to going into septic shock. Now, for the screening of sepsis, the Sepsis 3 guidelines recommend SOFA score. So SOFA score is required. A clinical criteria is a clinical criteria for diagnosing sepsis along with a suspected infection in the body. So an acute increase in 2 or more SOFA points is acting as a proxy for organ dysfunction, that it points towards organ dysfunction. So the SOFA score, it evaluates the various organs including respiration, that is the lungs, coagulation, liver, cardiovascular system, central nervous system, and the renal system. So for evaluation respiration, we consider the ratio of the arterial oxygen pressure along the inspired oxygen concentration, PaO2 by FiO2. For coagulation, we calculate the platelet count. For liver evaluation, we consider the bilirubin concentration. For cardiovascular, we consider the mean arterial pressure. For central nervous system evaluation, we consider the Glasgow Coma scale. And for renal evaluation, we consider two things. One is the creatinine concentration and another is the urine output. But nowadays, the SOFA, because it being a very lengthy thing, we now consider a new screening tool for sepsis, that is the quick SOFA score. A quick SOFA score has been proposed. A quick SOFA score of 2 or more, that is 2 out of 3, identifies a patient who will have a poorer outcome. So it will identify a patient who will have a poorer outcome. Now quick SOFA score has 3 criteria: the Glasgow Coma scale, the respiratory rate, and a systolic blood pressure. If the Glasgow Coma scale is less than equivalent to 13, respiratory rate is more than equivalent to 22 per minute, and systolic blood pressure is less than equivalent to 100 millimeters of mercury, any 2 out of 3, then the quick SOFA is positive, and 2 or more criteria suggest a greater risk of poor outcome. They compared the quick SOFA score along with SIRS and SOFA. So they found out that the quick SOFA score, it performed better than SIRS and SOFA in prediction of in-hospital mortality. That is, the specificity for mortality of a quick SOFA score was 84%. It was higher than SIRS and SOFA scores. So some of the organizations, they have started using the new sepsis guidelines and the quick SOFA for screening of sepsis, while some institutions still do not use. They use the elaborate SOFA system. Now we'll discuss the Surviving Sepsis Guidelines. The Surviving Sepsis Guidelines were given for the management of sepsis and septic shock. They were first published in 2004. Then updates came in 2008, 2012, then 2016, and then 2018. Latest are the 2018 ones. So it was first published in 2004. They have been discussing various bundles which give out points how to manage sepsis, basically. So these are specific selected elements which tell us how to go about the management of sepsis. So in 2008, there were 2 bundles. One was the resuscitation bundle, one was the management bundle. No longer considered, now totally changed. In 2012, we'll discuss, there were 2 bundles which included within 3 hours, the steps to be taken within 3 hours, and other one was the steps to be taken within 6 hours. So within 3 hours in 2012, it was recommended that within 3 hours, first we measure the lactate levels, we obtain the blood cultures prior to administration of antibiotics, then we administer the antibiotics, and if patient has hypotension, that is a mean arterial pressure of less than 65 mm of mercury, and or lactate levels more than 4 millimoles per liter, then we start the patient on crystalloids at a rate of 30 ml per kg. A few other points were given that had to be completed within 6 hours. So if the patient, despite the fluid resuscitation with crystalloids at a rate of 30 ml per kg, his mean arterial pressure does not improve above 65, then we add vasopressors. So we add vasopressors to it. Along with vasopressors, we guided through the measurement of central venous pressure, and we also monitor the saturation of oxygen in the central venous blood. After every 2 hours, it was also recommended to measure lactate if the initial lactate levels were elevated. But in 2016, a few changes were made. That is because the people did not know what is the time of presentation. So uh, they were not doing the things within 6 hours and within 3 hours. So in these they introduced the time for presentation in the 2016 to emphasize that timing within 3 hours of presentation and within 6 hours of presentation is very important. So time of presentation is when the first chart is made. Supposingly the patient is being treated at one hospital and then referred to another hospital, so time of presentation is actually the first chart made in the first hospital, that is first when the patient has started treatment in the first hospital, not according to the timings of the second hospital. That has to be considered. The time of presentation is important, and these guidelines have to be done according to the time of presentation at the first facility or the first treatment facility. That is within 3 hours as already discussed, and within 6 hours is already discussed. Now a few changes were made in the 2018 guidelines. The most important change was the revision of the bundles, that is the 3-hour bundle and a 6-hour bundle. They have been combined into a single 1-hour bundle. That is all these things. That is, one is measure the lactate levels, second is obtain blood cultures, third is to start antibiotics, and fourth is to administer fluid, administer crystalloids like 0.9% saline at a rate of 30 ml per kg. These all things plus requirement of addition of vasopressors and measurement of CVP or the saturation of central venous oxygen and remeasuring of lactate. These all, that is the 3-hour bundle and the 6-hour bundle, they have been combined into 1-hour bundle. That is all the things have to 1-hour bundle. That has all the things have to be done within the first hour of presentation. More than 1 hour may be required to complete, but initiation of this resuscitation should be completed within. It is not necessary to complete all the elements in the bundle within the 1 hour, but initiation of all these things should be done within the first hour. Remember that. So time of presentation or time 0 is defined where the first chart is made, remember, and all the things that we have discussed, they should be done within first hour of presentation, of the time of presentation or time 0. Now important thing is that we have to diagnose the sepsis using the quick SOFA or the SOFA score, and also as soon as possible we have to identify or exclude a possible source of sepsis. Prompt removal of IV devices have to be done if and other vascular accesses have to be done in cases of diagnosed sepsis or septic shock. Also, measuring lactate levels, as we have discussed, is very important. So how does lactate, it helps in sepsis detection? So lactate is not a direct measure of tissue perfusion. It just acts as a surrogate, but still it represents tissue hypoxia and accelerated aerobic glycolysis. Means how it is done, because in sepsis there is excessive beta adrenergic stimulation. Beta adrenergic stimulation is sorry. So there is excessive beta adrenergic stimulation. Excessive beta adrenergic stimulation leads to increased aerobic glycolysis, but at particular time the oxygen runs out, so it starts undergoing anaerobic glycolysis. So tissue hypoxia occurs, anaerobic glycolysis begins, and lactate levels are increased. So lactate levels increase in lactate levels is a indirect marker of tissue hypoxia or decreased tissue perfusion, right? And more than 2 millimoles per liter is considered as marker of tissue hypoperfusion. So first element in sepsis we know has to be to make a diagnosis of infection. So how do we make a diagnosis of infection? We make a diagnosis of infection by obtaining blood cultures. So it is said that blood cultures are the one of the first things to be done before starting antibiotic or antimicrobial treatment. So blood cultures, two sets have to be taken. One is an aerobic blood culture and second is anaerobic blood culture, because the infection sepsis can occur because of both aerobic as well as anaerobic infection microbes. So two sets always have to be done. One is aerobic blood culture and anaerobic blood culture. Before starting antimicrobial treatment, these antibiotics have to be started. So also it is said that if antibiotics are started as soon as possible at the time of presentation, within 30 minutes of presentation, then the hospital mortality is reduced to many folds. According to this chart, the odd ratio at the time of presentation, that is the 0 hour, is 1 odds ratio, and therefore very low hospital mortality is obtained if within 30 minutes or in the first hour of presentation the antibiotics are started. Also, for helping in the diagnosis of sepsis, there are various biomarkers which are being used currently. I will be discussing a few biomarkers. First biomarkers used are the acute phase proteins, acute phase reactants, or the acute phase proteins. So the acute phase reactant, the most important one being CRP and procalcitonin. Procalcitonin is a very good marker of sepsis now used nowadays. We'll be discussing this in a little detail. Also include pentatrixin 3. Other biomarkers include cytokines like IL-1 and IL-6, TNF alpha, and HMG binding protein 1. Then is cell surface markers like soluble CD14. Soluble CD14. It is also called as pre-sepsin. Soluble CD14. Some coagulation markers can also act markers of sepsis. These include APTT and protein C receptor. Okay. Some factors of which cause vasodilatation, they can also act as markers of sepsis, like copeptin. Copeptin can act as markers of sepsis, and some markers of cell damage can also be used as biomarkers of sepsis. Some factors of cell damage, these include microRNA and microparticles. So these are the one more thing is, seventh is the receptor markers. Some receptors, they also can act as markers, biomarkers, which can be used to detect sepsis. This includes SUPAR. SUPAR is soluble urokinase plasminogen activator. Soluble urokinase plasminogen activator. So these are the various biomarkers which can be used for the sepsis detection. So as we have already discussed, procalcitonin is one of the major biomarkers which can be used. It is an acute phase reactant. So discussing procalcitonin. So procalcitonin, it is a prohormone. That is not an active hormone, it is a prohormone of calcitonin. So inactive form of calcitonin, and because calcitonin is synthesized in the C cells of thyroid, so procalcitonin is also synthesized in the C cells of thyroid gland. So calcitonin also produced in ectopically in the lungs. It is also produced in the lungs and in the intestine. And this procalcitonin secretion is enhanced by bacterial exotoxins and endotoxins. Bacterial endotoxins and cytokines. They activate the procalcitonin release from the C cells of thyroid, and their levels they peak up in 6 hours. Remember, the levels peak in 6 hours, and the half-life of this procalcitonin is 24 to 36 hours. So as we have said, procalcitonin, it has got amino procalcitonin component and a calcitonin component. Amino component, when removed from the calcitonin component, releases calcitonin, which is a hormone. So procalcitonin is a precursor. It is a marker of severe bacterial sepsis, first used in children. As in Lancet 1993, it was said that it can be used as a very good marker for sepsis in severe bacterial sepsis. So earlier fungal and parasitic infections के लिए the PCT, the procalcitonin was not used. So only severe bacterial infections can be detected by severe bacterial sepsis. It can be detected by procalcitonin. So procalcitonin, it is a marker of bacterial sepsis. Procalcitonin can be slightly increased in parasitic and fungal infections too, and very low in viral diseases. So it is only a marker of bacterial sepsis. First published was in Lancet 1993, which said that it is a very good marker of severe bacterial sepsis, mainly in children, but now used in adults as well. Now discussing the sensitivity and specificity of procalcitonin to determine sepsis. The sensitivity of is around 77%, and specificity of detecting sepsis is 79%. So pretty good sensitivity and specificity for detecting sepsis. Procalcitonin can also be used for prediction of other things like pancreatic necrosis, etc. But as now discussed, it has a less specificity, because it can be increased in some other conditions like pancreatic necrosis. It can increase in viral meningitis as well. Can be increased in rheumatoid arthritis, etc. So that decreases the specificity of procalcitonin for detecting sepsis. Points again to note: it is a prohormone. Secreted by the C cells of the thyroid, activated by bacterial endotoxins and cytokines. Its levels increase in 6 hours, that is, it peaks in 6 hours, half-life is 24 to 36 hours. Ectopic production occurs in the lungs and the intestine apart from the C cells of thyroid. Lancet 1993 edition first said that it can be used for detection of severe bacterial sepsis, mainly in children. Slight increase occur of procalcitonin in fungal and parasitic infections, but there is a very low increase in viral infections. So procalcitonin is mainly a marker of bacterial sepsis. The sensitivity is 77%, specificity is 79%. Why specificity goes down? Because it can increase in a few conditions other than sepsis, like rheumatoid arthritis, in pancreatic necrosis, etc. So this was the discussion on sepsis biomarkers. Now, once we have detected sepsis, we start with antimicrobial therapy. It is generally considered that we give a combination therapy. It is generally considered that we give a combination therapy. That is, we give at least a combination of two antibiotics. Combination of two antibiotics is given that are aimed for the likely bacterial pathogen. First, empirical antibiotics are given till the blood culture results come, and then we can change to the specific antibiotic according to the culture sensitivity reports. An antimicrobial treatment should be given for 7 to 10 days, which is almost adequate for most of the serious infections for sepsis and septic shock. And procalcitonin levels measurement can be done after antibiotic treatment. So procalcitonin, as we have discussed, is a biomarker for sepsis, and decrease in the procalcitonin levels are very good prognostic factor. Prognostication of sepsis can be done with procalcitonin, and measurement of procalcitonin levels can be used to support the shortening of the duration of antimicrobial therapy in severe sepsis. So now next we'll discuss specific guidelines for the antibiotic therapy. So combination antibiotic therapy, as we have already discussed, is recommended for most of the patients, especially for neutropenic patients with severe sepsis and difficult to treat multi-resistant organisms like Pseudomonas, etc. And if the sepsis is associated with organ failure, especially respiratory failure, then or Pseudomonas bacteremia is there, combination therapy is definitely used. And if there is presence of shock, we prefer a combination therapy. So as in this chart, we can see that the 28-day mortality is reduced if a combination therapy is used, and the ICU stay is also reduced if in the presence of combination, that is two antibiotics being used simultaneously, both for gram positive as well as gram negative organisms. So next is the choice of antibiotic to use. So there are various scenarios which can be the source, the various organs which can be the source of sepsis. First is the community acquired pneumonia. So in community acquired pneumonia, as per the guidelines in the Clinical Infectious Diseases Journal 2007, it is recommended to use a beta-lactam antibiotic along with azithromycin, or instead of beta-lactam plus azithromycin combination, we can use a beta-lactam with respiratory fluoroquinolone use for community acquired pneumonia. Now we have to know what is a respiratory fluoroquinolone. It can be either levofloxacin or can be moxifloxacin. These two fluoroquinolones are the respiratory fluoroquinolones. If it is a hospital acquired pneumonia or nosocomial pneumonia, that is usually caused by Pseudomonas species, we can give an anti-pseudomonal beta-lactam. Anti-pseudomonal beta-lactams include piperacillin tazobactam. Piperacillin tazobactam can be used, or we can use cefepime. We can use meropenem, we can use imipenem, or Dorapinum. So these are broad spectrum anti-pseudomonal beta-lactam antibiotics. Along with that, we can give an aminoglycoside or an anti-pseudomonal fluoroquinolone. So anti-pseudomonal fluoroquinolones include levoflox and ciprofloxacin and levofloxacin. So ciprofloxacin or levofloxacin, anti-pseudomonal fluoroquinolone along with an anti-pseudomonal beta-lactam is most common combination used in hospital-acquired pneumonia, because these patients usually have chance of renal dysfunction. So aminoglycoside is usually avoided, but renal dysfunction is not there, we can give gentamicin, tobramycin, amikacin, aminoglycosides along with that. If an MRSA infection is suspected, then or staph infection is suspected, we can add vancomycin or linezolid to the bacterial antimicrobial course. So for hospital acquired pneumonia, we can use anti-pseudomonal beta-lactams like piperacillin tazobactam, cefepime, meropenem, imipenem, dorapinam, along with an aminoglycoside like gentamicin, tobramycin, amikacin, or an anti-pseudomonal fluoroquinolone. So combination of anti-pseudomonal beta-lactam along with an anti-pseudomonal fluoroquinolone like levoflox or ciproflox is the most commonly used combination. It can also be given in with an aminoglycoside instead of anti-pseudomonal fluoroquinolone in cases where there is no renal dysfunction. If an MRSA infection is suspected, example by that is the infection which is methicillin resistant Staph aureus infection, we can add vancomycin or linezolid. Next scenario is the catheter related bloodstream infections, that is by insertion of a urinary catheter that is causing a sepsis, that is called as catheter related bloodstream infection, also caused by other IV catheters that can be used, or the central venous catheters that can also cause a bloodstream infection, that are classified as catheter related bloodstream infections. So for catheter related bloodstream infections, these are usually caused by MRSA infections. So first choice is the vancomycin drug or daptomycin, along with an anti-pseudomonal beta-lactam. So as already discussed, anti-pseudomonal beta-lactam, it includes piperacillin tazobactam, and or can be used cefepime, or can use meropenem or imipenem. Okay, and then next is along with anti-pseudomonal beta-lactam, we can also give an aminoglycoside like amikacin, tobramycin, gentamicin, but is less preferred. It can be given if the two above antibiotics are still not effective. Then fourth is if there is a fungal infection that is suspected, then we can add an echinocandin. Echinocandin is very good antifungal for invasive aspergillosis or invasive candidemia, that is fungal sepsis. Echinocandin is a drug of choice. We can use caspofungin, anidulafungin, or mycofungin as the echinocandin drug. As discussed in the antifungal drugs video, the echinocandins can be remembered by the name by the mnemonic CAM. So caspofungin, anidulafungin, and mycofungin are the three echinocandins that can be used. These are cell wall synthesis inhibitors. Echinocandins, they are very good in invasive aspergillosis and invasive candidemia, that is fungal sepsis. The drug of choice is an echinocandin. If for combination we have to use, then we can add fluconazole to the treatment. So next case scenario. So the next case scenario is urosepsis. So urosepsis, we can use a third generation cephalosporin. Third generation cephalosporin includes ceftriaxone, cefotaxime, or we can use along with that we can use a fluoroquinolone. Fluoroquinolone, levoflox, ciproflox are the best choice, or we can use an aminoglycoside along with the third generation cephalosporin. So aminoglycosides like gentamicin, tobramycin, amikacin along with third generation cephalosporins, but they are not preferred because of the renal dysfunction they cause. If by chance there is sepsis because of an unknown cause, then we can use anti-pseudomonal beta-lactam like piperacillin, tazobactam, cefepime along with an aminoglycoside like gentamicin or amikacin along with vancomycin. So it will give a broad spectrum coverage and a broad spectrum coverage with an anti-pseudomonal beta-lactam like piperacillin, tazobactam, cefepime, meropenem plus an aminoglycoside or an anti-pseudomonal fluoroquinolone like levoflox or ciproflox can be used, but vancomycin can be used. So it is said that broad spectrum antibiotics, their administration are associated with lower mortality with an odds ratio of 0.86, and an odds ratio of 1 is achieved if these antibiotics are given in the first hour of the presentation to the hospital. Next, we'll discuss the pharmacokinetics of these antimicrobials, how they are altered in sepsis. So, remember the absorption. First, the absorption of the antibiotics, it is decreased in gastric and subcutaneous routes. Say the absorption is decreased due to shock. So gastric and subcutaneous routes, these are not preferred routes of administration, not preferred routes because due to shock the perfusion is less to these organs and therefore the absorption will be less. Therefore preferred route of administration is the IV route. Next point to remember is that volume of distribution of the drugs. So remember the hydrophilic medication, it tends to stay in the plasma. The hydrophilic administration, it tends to stay in the plasma, while the lipophilic medication, it tends to stay in the adipose tissue. So hydrophilic medication tends to stay in the plasma, while the lipophilic medication tends to stay intracellularly or in adipose tissue. So the hydrophilic medication will be influenced by fluid administration. So hydrophilic medication which tends to stay in the plasma, it will be influenced by fluid administration. So hydrophilic antibiotics, they include beta-lactams, aminoglycosides, they include beta-lactams and aminoglycosides, they include linezolid, and they include colistin. So the hydrophilic medication, they tend to stay in the plasma, that is their volume of distribution is mainly in the plasma, so they are influenced by fluid administration, so their concentration will change according to the fluid that has been administered. So beta-lactams, aminoglycoside, linezolid and colistin, their concentrations will change according to fluid that is being given, while the lipophilic medication, they tend to be intracellular, or in adipose tissue. So the adipose intracellular medication, they will not change by fluid administration. So the intracellular medication, they will not be influenced by fluid administration. Apart from hydrophilic medication, antibiotics, all others are lipophilic medications. Now third point is the loading dose. So goal is to achieve therapeutic concentrations. So first we give the loading dose, then only the maintenance dose have to be given. So we usually give the higher end of normal loading dose. The higher end of normal loading dose is recommended in sepsis. So example, vancomycin. Remember vancomycin. So the volume of distribution of vancomycin is vancomycin, remember, is a glycopeptide. Linezolid or vancomycin are glycopeptides. So vancomycin is hydrophilic medication. Vancomycin is hydrophilic medication. Its volume of distribution is that of hydrophilic medication, that is approximately 0.7 liters per kg. And for a 100 kg person, for a 100 kg person, the loading dose will be approximately 1 gram for vancomycin. To achieve a peak level of 14 micrograms per ml concentration of vancomycin in the blood. Remember that. Next is the influence of the renal function on the drug administration. So according to the Kidney Disease Improving Global Outcome KDIGO recommendations, the loading dose that depends on volume of distribution. So volume of distribution is increased in renal disease because of fluid retention. So volume of distribution increase in kidney disease. So hydrophilic medication that tends to stay in the plasma, their dose has to be increased, because these are the medications that depend upon the volume of distribution. So we recommend that the loading dose increase to 25 to 50% of normal dose, increase by 25 to 50%, that is 125 to 150% of normal dose should be given for the hydrophilic drugs. Hydrophilic drugs, again I am stating, these are beta-lactam antibiotics, these are aminoglycosides, these are glycopeptides like vancomycin or linezolid, and these include colistin. So for these hydrophilic medications that tend to stay in the plasma, we need to increase the loading dose by 25 to 50%, that is 125 to 150% of the normal dose have to be given. While maintenance dose, we do not change dose for maintenance in kidney disease. Also for kidney disease, chronic kidney disease, we recommend that therapeutic drug monitoring should be done. So this was according to the kidney disease improving global outcomes guidelines, KDIGO guidelines. Now next comes the fluid resuscitation. So it has been recommended that the initial fluid resuscitation within the first hour of time of presentation of a sepsis patient, we should give 30 ml per kg of IV crystalloid. Following the fluid initial administration, additional fluids have to be given, guided by the reassessment of the hemodynamic status of the patient. So the question comes, which of the fluids to be given? So the most preferable are the crystalloids, which include normal saline and ringer lactate. The compositions of crystalloids are given as here. So the preferred are the ringer lactate and 0.9% saline. So 0.9% saline contains 154 milliequivalents per liter of sodium, 154 milliequivalents of chloride, and no lactate and acetate. While the ringer lactate contains 130 milliequivalents per liter of sodium, 111 milliequivalents per liter of chloride, and 25 milliequivalents per liter of lactate. The other solutions are and their compositions are given here, which you can read. But remember, colloids are to be avoided. Colloids are avoided. Gelatins and starch never to be given. Gelatin and starch never to be given. Albumin, it can 4% albumin. In fact, 4% albumin can be considered in refractory hypotension. In refractory hypotension. So the treatment of choice for fluid resuscitation is the ringer lactate and normal saline. Ringer lactate contains 29 milliequivalents per liter of lactate along with sodium and chloride, while the normal saline contains 154 milliequivalents per liter of both sodium and chloride. These are the fluids of choice for resuscitation in a patient of sepsis. Now, time 0 at the time of presentation, we start with 30 ml per kg of fluid. No exclusion criteria, has to be started in all the patients. Then for continuation, we have to use crystalloids only. Only in refractory hypotension we can give albumin. So within first hour of presentation, if the hypotension is persistent, hypotension is said to be persistent if the mean arterial pressure remains below 65 mm of mercury even after fluid administration. Even after fluid administration, the mean arterial pressure remains below 65 mm of mercury, then it is considered as refractory or persistent hypotension. In that case, we can give albumin sometimes, but then as per the guidelines, the vasopressors have to be started within the first hour of the time of presentation. Hypotension, apart from the mean arterial pressure, has also been guided by the lactate levels. Lactate levels more than 4 millimoles per liter is also considered as one of the guides for definitions for persistent hypotension. We can do the shock assessment by physical signs like the vitals, cardiopulmonary examination. We can check the capillary refill, peripheral pulses. All the peripheral pulses have to be checked, and skin evaluation for turgor of the skin, if it's dry or not. Hemodynamic variations, these are the 4 hemodynamic variables which can be used for assessment of shock. One is the central venous pressure, the central venous oxygen saturation, cardiovascular ultrasound to do the various measurements, and passive leg raising or the fluid challenge test, which we will discuss in the subsequent slides. Now, next is the choice of the vasopressors. But before that, one point has to be remembered, that sometimes if there is a decrease in the hemoglobin concentration also, that there is presence of anemia, we recommend RBC transfusion, and we have to bring the hemoglobin concentration to 7 grams per deciliter. According to the latest TRIS guidelines, TRIS trial, that is the transfusion requirements TRIS trial. TRIS trial is the transfusion requirements in septic shock. So the transfusion requirements in septic shock trial was given. So that states that the hemoglobin concentration should be targeted to 7 gram per deciliter and not 9 grams per deciliter. Earlier it was considered as 9 grams per deciliter, but it was found that the 90-day mortality of both the levels are the same. So 7 grams per deciliter is the new target of hemoglobin concentration. So this was the RBC levels, and now we'll come to the choice of vasopressors. So the first line of choice is the norepinephrine. Norepinephrine is the first choice. Second line drugs include epinephrine and low dose vasopressin. And if these drugs also not work, then we can use dopamine if there is presence of sinus bradycardia, or phenylephrine if there are high cardiac output states or tachyarrhythmias are used. The latest guidelines, they do not recommend IV hydrocortisone for treatment of septic shock. If the patient is have to be achieved with a normal mean arterial pressure, then we can use IV hydrocortisone. IV norepinephrine. IV hydrocortisone not to be used. IV hydrocortisone not to be used. But still, if all the vasopressors are used and still we are not achieving the appropriate blood pressure, then 200 milligrams of hydrocortisone per day can be used. So this was the thing. Generally we avoid dopamine, phenylephrine, but in cases of sinus bradycardia we can use dopamine. In cases of high cardiac output we can use phenylephrine. Norepinephrine first line of choice. Epinephrine and low dose vasopressin are the second lines. Avoid dopamine and phenylephrine. Never to use IV hydrocortisone except for cases of vasopressor failure. Okay, so once again repeating, the guidelines suggest against using IV hydrocortisone to treat septic shock patients if vasopressor therapy has been able to restore hemodynamic stability. But if the hemodynamic stability is not being achieved by vasopressors also, we can use 200 milligrams of hydrocortisone per day if vasopressor, in cases of vasopressor failure. So also to remember that 200 milligrams hydrocortisone maximum for 7 days have to be given, not more than that. And then we have to taper in cases of sepsis. We have to taper in cases of sepsis after 7 days. Okay. And no ACTH stimulation. Also remember, no ACTH or serum cortisol level checking required before hydrocortisone administration. But remember, do not use hydrocortisone as such if adequate blood pressure is maintained. That is the last choice only if vasopressor failure has occurred. There are also some recommendations of using vitamin C in sepsis, in treatment of sepsis, and a few journals have released articles in which there is evidence of vitamin C and thiamine being used in the treatment along with the normal therapy for the treatment of severe sepsis. So these are the two other things that can be used in severe sepsis. One is vitamin C and other is thiamine. So now what is the goal of initial resuscitation? The goals of initial resuscitation, as per the treatment protocol, the goals of initial resuscitation, number 1 is achieving a central venous pressure of 8 to 12 millimeters of mercury. Number 2, achieving a mean arterial pressure of more than or equivalent to 65 mm of mercury. Number 3, achieving a urine output of more than or equivalent to 0.5 ml per kg per hour. And number 4, achieving a saturation of central venous oxygen, that is central venous oxygen saturation of more than or equivalent to 70% oxygen saturation. So the goals of initial resuscitation include a central venous pressure of 8 to 12 millimeters of mercury, mean arterial pressure of more than or equivalent to 65 mm of mercury, urine output more than or equivalent to 0.5 ml per kg per hour, and a saturation of central venous oxygen more than or equivalent to 70%. These are the goals of initial management. So, for if the patient has come and the patient is in severe sepsis, as per earlier is in sepsis, the severe sepsis has been eliminated. If the patient is in sepsis and needs intubation, this is the case scenario. So first we give supplemental oxygen or endotracheal intubation if required. We measure, we insert a central line, and central venous line, and central venous and arterial catheterization is done. Patient is sedated and paralyzed if the patient is intubated, or both can be given in order to administer effective ventilation. We measure the central venous pressure. If the central venous pressure is less than 8 millimeters of mercury, we give crystalloids. If the patient is refractory to crystalloids, we include albumin in the regime. 4% albumin can be used. If the central venous pressure it becomes 8 to 12 millimeters of mercury, we move to the next step, that is measuring the mean arterial pressure. If the mean arterial pressure is less than 65 mm of mercury, we administer vasopressors. So vasopressor of choice is noradrenaline or norepinephrine is the first line of choice. The second line includes epinephrine or can include vasopressin. So these are the two second line choices. Do not use dopamine unless there is sinus bradycardia. Do not use phenylephrine unless there is tachyarrhythmias or high output cardiac states. Do not use those drugs, and do not use IV hydrocortisone also. If by vasopressors the mean arterial pressure becomes more than 65, we move to the next step, that is measuring the saturation of central venous oxygen. If it is less than 70%, we transfuse red cells until the hematocrit is more than 30%. If the saturation becomes more than 70%, we move to the next step, that is all the goals are achieved. And if the patient oxygen saturation is still less than 70% despite the red cells being transfused, if it is still less than 70% despite the administration of fluids, then we move to the next step, that is transfusion of RBCs do not achieve a saturation of oxygen more than 70. We move to the next step, that is inotropic agents that will increase the saturation to more than 70%, and the goals will be achieved. This was the management protocol. So always remember that lactate levels they can be used as surrogate markers for the guiding the resuscitation. Elevated lactate levels more than 2 millimoles per liter are an indicator of tissue hypoperfusion. So lactate levels, they're always a good indicator of tissue hypoperfusion. Secondly, we can also use procalcitonin levels. They can be used as markers of prognostication of antibiotic therapy. Prognostication of antimicrobial therapy. So the procalcitonin levels are a marker of bacterial sepsis. They are a marker of bacterial sepsis, And the procalcitonin levels, they decrease after antimicrobial therapy, and they can be used for successful end stage of antimicrobial therapy, and also helps in shortening the course of antimicrobial treatment. Next, we'll come to volume assessment parameters. So there are two types of volume assessment parameters. One are the static parameters, and the other are the dynamic parameters. So static parameters, they include central venous pressure, pulmonary artery occlusion pressure, right ventricle end diastolic pressure, on left ventricle pressure or volume, both can be used, right ventricle and diastolic volume. So central venous pressure, pulmonary artery occlusion pressure, right ventricular and diastolic volume of pressure, and left ventricular and diastolic volume are the four static parameters for volume assessment. The dynamic parameters, these are much commonly used nowadays, are the systolic pressure variation, the pulse pressure variation, IVC collapse rate, IVC collapse, and the passive leg raising test. So it has been said that for fluid resuscitation, it is recommended to use CVP, but nowadays CVP is no longer considered a adequate assessment, adequate parameter for volume assessment. CVP is not considered nowadays for as a adequate parameter for volume assessment. So the guidelines no longer recommend lone static fluid measurements, but static parameters for the volume assessment. The 2018 guidelines, they recommend the use of dynamic variables over these static variables. The dynamic variables are much better as compared to the static variables to predict the fluid responsiveness. These dynamic variables, again repeating, include the systolic pressure variation, pulse pressure variation, IVP collapse, and passive leg raising test. So discussing these parameters one by one. First is the systolic pressure variation. So systolic pressure variation, it includes the variation in systolic pressure according to the respiratory cycle. So systolic pressure there is a downfall in inspiration, systolic pressure. So the respiratory cycle induced change in the parameters of systolic pressure can be used as a predictor of the volume status of the patient. So a threshold value of 5 mm is used. So threshold value of 5 mm of systolic pressure variation is used. So systolic pressure variation is the SP max minus the SP minimum. So maximum of systolic pressure minus the minimum is the systolic pressure variation. So a threshold of 5 mm of systolic pressure variation has been associated with increase in stroke volume of 15%. So systolic pressure variation threshold of 5 mm has been used, and at least 5 mm should be achieved for adequate volume in body after fluid resuscitation. So 5 mm of systolic pressure variation increases the stroke volume by 15%, and this is the adequate parameter which should be present for assessment of adequate fluid resuscitation. Next is the pulse pressure variation. Pulse pressure, as we already know, is the systolic pressure minus the systolic blood pressure minus the diastolic blood pressure. The systolic blood pressure minus the diastolic blood pressure is the pulse pressure. pulse pressure variation is the pulse pressure maximum minus the pulse pressure minimum upon plus pulse pressure maximum plus minimum by 2. So the pulse pressure variation is the value which has to be taken. The change in the pulse pressure, if it is low, that means no effect of stability, no effect, that is beneficial hemodynamic stability has not been achieved, hemodynamic stability not achieved by fluids alone. Okay, so the pulse pressure variation, if it is low, how do we define it as low? Less than 13%. If there is pulse pressure variation is less than 13%, that means fluids not adequate for achieving the hemodynamic stability. However, if pulse pressure variation is more than 13%, then there is improvement in cardiac output, and fluid resuscitation is adequate. Fluid resuscitation is adequate to achieve hemodynamic stability. Fluid resuscitation is adequate to achieve hemodynamic stability. So as we have discussed, the next is the passive leg raising test. Passive leg raising test. So passive leg raising, that is for this is the normal at 0 degrees. The patient is lying down, and by 45 degrees we raise the legs of the patient. By passively raising the legs of the patient, it transfers a significant volume of blood from the lower part of the body towards the heart. That is, it empties the venous reservoir in the legs and it transfers the blood from the legs to the heart. In this connection, the passive leg raising increases the cardiac preload, and eventually it increases cardiac preload, increases cardiac output, and therefore it improves the blood pressure. Okay. Since these tests, they exert a very severe effect on the cardiac and respiratory cycle, therefore we have to first see that the patient does not have any tachyarrhythmias. So exclude tachyarrhythmias and exclude decreased respiratory rate. First to exclude these two things, and then only do the passive leg raising test. Okay, so passive leg raising is raising the legs to 45 degrees. It will move the venous reservoir of blood from the legs to the cardiac chambers. The cardiac preload will increase. It will increase the cardiac output. So patients who are fluid responsive, they will show a 10 to 15% increase in the stroke volume in the first 30 to 90 seconds. Again repeating, the patients who are fluid responsive, that is adequate fluid resuscitation is achieved, that is the patient is able to achieve a mean arterial pressure of more than 65 with the fluid resuscitation, or the patient is now hemodynamic stable just by fluids. So adequate fluid response has been achieved. So fluid response is positive if the patients are able to achieve a 10 to 15% increase in stroke volume or increase in cardiac output in 30 to 90 seconds of passive leg raising. Okay, so the fluid response by passive leg raising is positive if there is a 10 to 15% increase in the stroke volume cardiac output in 30 to 90 seconds of passive leg raising. This is considered a positive fluid response in the patient of sepsis as measured by the passive leg raising test. Benefit of passive leg raising can be that the patient, it is a self volume test. We do not have to administer anything from outside. It is a self volume challenge test, and the passive leg raising test is reversible. It is not an irreversible test. We are not administering anything from outside. It is a reversible test. So these are the benefits of passing. First, the self volume challenge test. Second, the passive leg raising test is reversible test. The last is that we have to measure is the last thing that we are studying is the saturation of central venous oxygen, that can also be used as a good parameter for assessment of fluid assessment of hemodynamic status after fluid administration. So in arterial blood there is 100% oxygen saturation, 100% saturation of oxygen, say. And then when it comes to the capillaries or the peripheral tissues, the capillaries, the 25% is extracted, 25% extracted. So out of 100%, 25% extracted, so that goes into the venous blood is 75% of oxygen. So central venous blood should contain 75% of oxygen. Oxygen delivery is related to cardiac output. Cardiac output, it influences the oxygen delivery. Since the oxygen extraction is independent of oxygen delivery, the cardiac output is directly related to the central venous oxygen. Okay. So the central venous, we can say that central venous saturation of oxygen is directly related to the cardiac output. So the higher the central venous oxygen, the more will be the cardiac output, and we can say that the hemodynamically stable patient may be there. But some things can exclude the, or it can be a limitation for the use of central venous oxygen saturation. Like central venous oxygen saturation can also be normal in patients with tissue hypoxia. It can be normal in patients with shunts and end stage lung disease having shunts, and may be normal if the patient the tissues, they are not able to extract the oxygen from the arterial blood.